Hello, I'm Hayley.
And I'm Philly.
And we are specialist OTs in the Northamptonshire Community Stroke team. Today we're going to talk to you about how we've adapted to remote working and ideas for completing occupational therapy treatment via video and telephone calls. As Paul and Sarah mentioned, part of us adapting to remote working has involved us in completing initial assessments via telephone where appropriate, to try and establish the patient's exact needs, and then if face-to-face is required. Where possible, we will then follow up with sessions via telephone and or video call through using the Attend Anywhere platform. We then subsequently send activity plans and exercises via email prior to and following our sessions for patients to continue working on with the support of family or on their own. So the following slides we're going to talk about today discuss treatment ideas for a range of areas within occupational therapy that both myself and colleagues have completed. So the first slide is about home assessment remotely and equipment provision. We have a template worksheet which consists of house measurements which we can ask for carers to complete and send back to us via email. This form contains information regarding furniture heights, door widths, access points, and so on, and helps us identify possible adaptations that may be needed. We've also been able to gather information about patients' home environments by observing their home via video tour. We do this via a carer often, who can then show the space and rooms for equipment, for example, a hoist or a rail placement. And if video calling isn't viable, you can always ask photographs of the patient's home and get the carer or the patient themselves to send them via email. Once the equipment has been provided based on this, it may be possible to demonstrate the use of equipment. For example, a colleague of ours has used online video clips to demonstrate how the equipment works and ask the patient and carer for feedback on this and how they feel using it. You could also demonstrate for safety purposes via video. Also, to reduce the number of staff entering into patients' homes and houses, we've completed joint sessions, for example, one therapist attending remotely. We've done this via physiotherapists attending people's homes for the visit to assess mobility, and then the OT joining remotely to assess their environment.
So the next one is about treatment ideas for cognition. So as discussed in a previous remote rehab webinar about cognitive assessment, the following areas can be treated with the same principles remotely. So just very briefly, attention could be done through worksheets sent via email prior to the session. You can assess the setting up of the platform that we use as part of their treatment as well. Attention card games, divided attention exercises. So for example, giving the patient 2 tasks to do at once, either switching between the 2 and asking for target kind of words and things that they're looking out for in particular tasks. So memory can also be treated again through games, complete recall tasks, so giving them words at the beginning of the session to remember and seeing if they can recall later. And you can try and complete the education of compensatory strategies remotely as well, and that can either be done via video or telephone. So executive functioning can also be treated with problem-solving worksheets, pictures. You could complete organisation and planning tasks and worksheets sent by email. You could do money management tasks via video. And also giving patients tasks for self-monitoring as well. Apraxia, again, sequencing tasks with errors put in. So the therapist could be following through with a task and putting some errors in for the patient to try and identify. And you could do object recognition tasks as well, and gesture and imitation work. And visuospatial and perception. So again, worksheets could be sent via email. So we've often sent things like hidden object worksheets, inattention work, so like star cancellation, line bisection, etc. And also then orchestrating a busy environment in a functional task and seeing if the patient can see where objects are and follow through with the task in that busy environment. And most of those, if needed, can be done with a carer and liaising with them first, I guess, to set up the session and then following through with the patient. So Paul touched on upper limb, but I'll go through how we've used remote technology for upper limb as well. So we've asked patients to complete functional tasks while we're observing via video. So this has included things like applying face cream, simulating brushing teeth, combing their hair, handwriting and cooking tasks, for example, giving them specific upper limb exercises they need to complete in between. So you could do a joint session with the carer for stretching and assisted work. So giving the carer a stretching plan by email, for example, and asking them to complete those over video call. And then you can also then feedback about their technique. Following assessment of upper limb, we would usually send out an activity plan with exercises. And then we complete video sessions where the therapist can demonstrate the exercises for the patient to copy. So for example, therapist demonstrating reach and grasp, the patient then using household objects to copy that movement, and then the therapist can feedback on their technique. And by using the video call, the patient can also observe their actions by watching themselves and then can better understand what their upper limb movements are like and see where their technique might not be effective. I've also completed motor imagery sessions where I've read through a script for a patient to listen to and complete principles of mental imagery. And again, the patient within that can also attempt those movements at the same time if able. And some of my colleagues have done constraint-induced movement therapy. So they've done that by asking the patient to wear a glove on their non-affected hand and then completing specific tasks, for example, using a remote control, doing up buttons on a shirt, and using their mobile phone, for example, to text. And also eSTIM as well, as Paul said. So when set up from a face-to-face visit, normally we would set up eSTIM and then can follow that up with some remote sessions, incorporating reach and grasp in conjunction with it, for example.
We've also found remote rehab can also be utilised within functional activities. For instance, based on our patients' goals, we've completed a number of tasks remotely for upper limb treatment, cognition work, as well as building activity levels for fatigue management and helping patients establish routines. We've completed kitchen tasks such as hot drink practice. You can do this with a carer if it's needed for safety, as well as prepping vegetables and meals, asking the carer to video the patient, but also you can get the patient themselves, if they're able, or a family member, to set up a camera before the session. As Vinny mentioned earlier, you can also get patients to complete grooming tasks such as combing hair, brushing teeth, and applying makeup. These are all great for upper limb treatment, but also can be used to treat cognition, such as apraxia. You can also ask patients to complete domestic tasks, for example, loading and unloading the dishwasher, folding laundry, and dusting. A lot of my patients have set goals related to their handwriting, and this is great over remote rehab. You can achieve this by sending handwriting sheets via email or asking the patient to repeat the same paragraph every week to try and monitor their progress. We've also found it quite useful to ask the patient to time how long it takes and the number of errors they make. And this is quite useful if you want to use it as an outcome measure. In terms of medication management, you can send them medication tick sheets for patients to complete, but also complete remote sessions at a time when patients need to take their medication to either supervise but act as a prompt. And you can do this in conjunction with carers to try and upskill and train those in their area. Okay, so one of the patients where remote rehab was particularly useful for me was a 19-year-old male who, when he first started his rehab journey, had approximately 2 out of 5 movement dystally in his left upper limb. A lot of his goals related to activities involving bilateral movement, and it's quite apparent that his attention was also significantly reduced, and this was impacting quite a lot on his sessions with the wider MDT. To work on both these areas in which he felt were both goal focused, I completed a lot of remote rehab incorporating his upper limb and functional tasks. And I often completed these activities with him. Being a young lad, it tried to take the onus off of him. One of the sessions that I completed with him, he chose a muffin recipe, and we both made this separately in a video call. This provided an opportunity for him to incorporate his upper limb, but also worked on his divided attention between the task and the call. After the session, we then sent pictures to one another of our finished product via email, and this allowed him to self-monitor, but also get a bit of self-achievement regarding it. I've also completed workout sessions with him, which incorporated exercises that provided sensory feedback through the upper limb, doing activities such as mountain climbers. And then to integrate cognitive elements, I would set a rule, for example, get him doing one exercise, and when I did a specific action, such as a clap, he would need to switch to another. Feedback from him was that he found these sessions really fun, and whilst being goal focused, also provided an opportunity for us to complete the sessions together.
So case study 2, just very briefly how we've used remote technology within home visits, as we kind of briefly spoke about earlier. So this chap is 62 years old. He was discharged from hospital to a specialist care centre. So there were some concerns about his ability to manage at home due to physical, speech and cognitive deficits. So he lived alone prior to his stroke and now requires care for all of his activities of daily living. His stroke also resulted in no active movement in his upper limb and associated pain. So his main goal was to return home safely, and we established this through kind of speech and language therapy sessions, and lots of discussion with him about how we were going to manage that safely. So through remote therapy, a home visit was completed to assess his safety, and we did this jointly with physio and speech therapy. So the physiotherapist and the speech therapist went on the home visit to assess mobility around the home and on the stairs, and the speech and language therapist to help with communication during the visit and to assess his understanding. And then to reduce the number of people present at his house in light of the current pandemic, I observed the session via video. And again, this also helped him in terms of reducing that pressure. I mean, 3 therapists all at once in his home environment could be quite overwhelming for him. So I was there remotely, and I was there to look at his home environment for any equipment needs, checking safety of kind of door thresholds and things like that. And also he completed a functional kitchen task during the session, so I could observe how he managed with that in terms of cognition and safety. So we were able to collaboratively assess whilst using remote technology to reduce risk. So that's it. So thank you to our OT colleagues within the team for contributing to the presentation with examples and ideas for treatment. For any further advice, please email us or access Remote Rehab